Okay, so I want to start today with a number. It's from the Cognitive Resilience Report. And it honestly kept me up last night, 5.7%.
It sounds so benign when you just say it like that, doesn't it?
Right.
A little over 5%. It almost, it sounds like a rounding error.
Exactly.
You know?
But let's look at what that number actually represents. We're talking about the emergency department here. That 5.7%, that's the misdiagnosis rate.
So that means 1 in every 18 people.
1 in 18 people walking through those ED doors is getting the wrong label attached to their problem.
And when you scale that up, I mean, you think about the sheer volume of emergency care in the U.S., the implications are just massive.
We're not talking a few thousand people.
No, not at all. We're looking at about 7.4 million misdiagnoses every single year.
And the report put a very, very human price tag on that, too. It leads to 2 million harms and roughly 350,000 cases of
Permanent disability or death.
Yeah.
It's just staggering.
It is staggering. And my first reaction, looking at this was honestly a bit of anger. I mean, we treat medicine with such reverence. Doctors go through years of this intense, grueling training. How is the margin of error this high? Is the training failing?
Well, it's the natural question to ask, but if we go down that road of blaming individual competence,
Yeah.
we really miss the point entirely.
Okay.
The source material makes it very clear this isn't usually about incompetence or doctors not knowing their textbooks. It's about a fundamental clash
A clash between what and what?
between the way the human brain has evolved to process information and the specific high-velocity environment of the modern emergency department.
So you have a brain that wants order and time to think.
Exactly. A brain that craves patterns placed in a setting that's just defined by chaos, interruptions, and, information scarcity.
So the environment itself is just hostile to clear thinking.
Precisely. So the mission of this deep dive isn't to point fingers at burnt-out clinicians. It's to equip emergency clinicians, and really anyone interested in high-stakes decision-making, with what the authors call a cognitive shield.
A shield against the chaos.
Yeah.
And we've got a very specific two-phase methodology to unpack today to build that shield.
Right.
We're going to talk about problem representation, which sounds academic, but is actually incredibly practical, and then a framework called SBOT decks.
These are the tools. They're designed to stop the brain from, taking the path of least resistance.
Before we get to the solution, though, I want to understand the problem better, this architecture of error. The sources spent a lot of time on System 1 and System 2 thinking. Now, I know we hear these terms a lot in, pop psychology, but how does this play out when a trauma alert is going off?
Okay, so System 1 is your fast brain, your intuitive brain. It's all pattern recognition. In an evolutionary sense, you see a shape that looks like a snake, you jump back, you don't analyze the scale pattern first. In the ED, this is seeing a patient clutching their chest and instantly thinking ischemia.
And you need that for speed.
Oh, you can't function without it. But the report implies that System 1 is a bit of a trap.
A seductive trap, I think they call it.
It is, because it feels good to use it. It feels like confidence. When you just know, you feel like a master clinician. The problem is System 1 relies on shortcuts and biases. It anchors on the first thing it sees.
And System 2.
System 2 is the slow one, the analytical, logical brain. It's the part of you that does long division or, solves a riddle. It checks the work.
So it's essential for accuracy.
Right. But here's the catch that the report really emphasizes. System 2 is metabolically expensive. It drains your battery.
And the emergency department is basically designed to drain that battery, isn't it?
That's the crux of the issue. You have to think about cognitive load. Every time a monitor beeps, every time a nurse asks for a signature, every time a consultant interrupts, that depletes your System 2 bandwidth.
So by the 6th hour of a shift,
your brain is physiologically desperate to conserve energy. So what does it do? It defaults back to System 1. It goes on autopilot to save itself.
you start relying on intuition when you should be relying on analysis because you literally don't have the energy left to think deeply.
That's it. That's where the cracks form.
The report also mentions something called distributed cognition. It's not just one doctor's brain failing. It's like a game of telephone gone wrong.
Oh, the handoff is a minefield. Yeah. Errors often happen in the relay. A nurse tells a resident a patient has flank pain. The resident tells the attending it looks like kidney stones.
By the time the attending sees the patient,
Everyone is anchored on kidney stones because there's this massive social pressure to present a neat, tidy story.
nobody wants to be the one to say, actually, the data is messy and I don't know.
Exactly. And because everyone agreed on the story, nobody noticed that it was actually a leaking aortic aneurysm.
Which brings us to the big five. The sources identify 5 conditions that are responsible for the most harm. We're talking stroke, MI, aortic aneurysm dissection, spinal cord injury, and VTE blood clots. My question is, why these 5? There are plenty dangerous diseases out there. Why are these the snipers?
It's not just that they're deadly, it's that they are masters of disguise. They are the great mimics.
Give me an example of the disguise.
Okay, take aortic aneurysm. It often doesn't present with that classic tearing chest pain the textbooks promise. It presents as back pain or flank pain.
Which looks exactly like a kidney stone or a pulled muscle.
Exactly, and a stroke. It can look like simple vertigo or a migraine. So if you are operating purely on system 1, that fast pattern recognition, you will miss them. Your brain just says back pain equals muscle strain, and you move on.
So we need to force our brains to stop that script. And this brings us to phase 1 of the solution, the art of problem representation.
This is the foundation. It really is. Problem representation, or PR, is the act of translating that raw, messy story the patient gives you into abstract medical concepts.
The sources call it the one-liner. And it's a formula, right? It seems like a lot of work, but it answers 3 questions. Who is the patient? What's the temporal pattern? And what's the clinical syndrome?
It is work, but it's high-yield work. It's mental engineering. And the most critical anchor here, the one the report says novice clinicians miss constantly, is the temporal pattern, time.
Let's break that down, because time isn't just when did it start. It's a category.
Correct. You have hyperacute, which is onset in seconds to minutes. That just screams vascular issues, something bursting, twisting, or blocking.
Okay.
Then you have acute hours to days. Think infection, inflammation. Acute on chronic is a sudden worsening of an old problem. And then chronic, of course, is weeks to months.
Okay, I want to see this in action, because this is where the theory, hits the pavement. Use that back pain trap. I'm going to give you the novice framing.
Let's do it.
Okay. Novice doctor says, I have a 60-year-old man with back pain for 2 hours.
Okay, stop. Stop right there. That framing is dangerous. Back pain triggers a muscle strain script in your brain. It just sounds benign. 2 hours is just a duration. It doesn't tell me the speed of the onset.
So how does an expert frame that same patient?
An expert would say something like, I have a 60-year-old male with vascular risk factors presenting with a hyperacute severe tearing thoracic lumbar syndrome.
Wow. Okay, that feels like a completely different patient.
It triggers a completely different physiological search pattern in your brain. The word hyperacute, combined with tearing syndrome, immediately points to the aorta. You are no longer thinking about muscles or discs. You are thinking, I need a CT scan now.
It's almost like the words you use to describe the problem dictate the solution.
They absolutely do. Language is the operating system here.
Let's do one more. The cough trap, Nava says. Elderly woman with fever and cough.
Sound like the flu, right? Or maybe a little bronchitis. Send her home with fluids.
But the expert says,
75-year-old immunocompromised female with an acute progressive lower respiratory syndrome.
And suddenly I'm not thinking flu. I'm thinking sepsis. I'm thinking opportunistic pneumonia.
Exactly. Immunocompromised changes the who. Acute progressive changes the time. You've moved the patient from the urgent care bucket to the ICU bucket just by changing the sentence.
So step 1 is getting that one-liner right. But the sources warn that even with a good PR, you can still screw it up.
Oh, absolutely. You can have the perfect summary and still jump to the easiest conclusion just because your brain is tired.
And that is where phase 2 comes in, the SPOT-DX strategy.
SPOT is a mnemonic, but don't let that fool you. It's a cognitive forcing function. It's a mental speed bump you intentionally hit to force System 2 to wake up.
Okay, so let's walk through it. SPOT, it starts with S for serious.
Or rule out worst case. This is where you have to fundamentally ignore probabilities, which is hard, right? We're taught to look for horses, not zebras. But in the ED, you have to ask, if I am completely wrong, what is the most dangerous thing this could possibly be?
The until proven otherwise rule.
Yes. For example, if you have thoracic pain plus any neurological symptom like a tingling leg or a bit of dizziness, that is an aortic dissection until proven otherwise. I don't care if they lifted a heavy box yesterday, the stakes are too high.
Or a headache with a thunderclap onset. That instant 10 out of 10 pain.
That is a subarachnoid hemorrhage. A brain bleed until proven otherwise. You cannot discharge that patient until you are 100% sure it isn't that. You screen for the killer first.
Okay, so S is the safety lock. Moving to P, probable or possible. And the sources suggest using a sieve called DIMES here.
Right. This is to prevent tunnel vision. You check 5 categories to make sure you haven't missed an entire system. DIMES.
So D is for drugs and toxins. Is this really a big enough category to be first?
Oh, it's huge, especially in the elderly. A patient comes in confused and falling. Is it a stroke? Maybe. But maybe they took 2 Benadryl and a sleeping pill.
Or they're in withdrawal.
Exactly. If you don't ask what did they take, you'll start ordering MRIs for a medication side effect.
That stands for infection and inflammation.
Sepsis is the big one here, but also, autoimmune flares. Could that back pain patient actually have a spinal abscess?
Metabolic. The sources call this one the great mimicker.
And it is. This is my favorite category for saves. Hypoglycemia, low blood sugar, is a chameleon. It can look like a stroke with paralysis. It can look like psychosis. It can look like just being tired.
And if you don't check the sugar,
You might call a code stroke, rush them to CT, maybe even give dangerous clot-busting drugs when all they needed was a sandwich and some juice. You have to check the M.
E is endocrine. I feel like this one gets forgotten a lot.
Constantly. We miss it because it's so vague. Think about adrenal insufficiency. The patient presents with weakness, maybe some vomiting, low blood pressure.
Which sounds like every stomach bug ever.
It does. So if you don't have endocrine on your checklist, you will send that patient home with gastroenteritis. And if they have an adrenal crisis at home, they die. You have to actively ask, could this be thyroid? Could this be adrenal?
And finally, S for structural. Trauma, fractures, that sort of
That's
thing.
physical stuff, yeah.
So DIMES, make sure we've scanned the whole horizon. Now we come to O in CCUTT. O is for outliers.
Ah, my favorite. I call this the Columbo step. Just one more thing.
Excuse me, sir, just one thing bothers me.
It's the fight against confirmation bias. You have a working diagnosis. Let's say you think it's anxiety. Now, you have to actively look for a piece of data that contradicts that diagnosis. You ask yourself, what does not fit?
Give me a concrete example. An outlier that gets ignored because it's inconvenient.
Okay, a young patient, you've diagnosed them with a panic attack, hyperventilating, tingling fingers, upset. Classic anxiety, right?
That's right.
But the nurse recorded a temperature of 100.4, just a low-grade fever.
Anxiety doesn't cause fever.
Precisely. The fever is the outlier. If you ignore it because it ruins your neat little anxiety theory, you're in trouble. That fever might mean the hyperventilation is actually hypoxia from a pulmonary embolism or, early sepsis.
Or a patient with a simple viral cold who has a heart rate of 110.
Right. The tachycardia is the outlier. Why is their heart racing if it's just a runny nose? You have to explain the outlier.
The sources also mention this concept of embryonic illness.
It's a great concept. It's the idea that the patient might be in the very, very early stages of something bad. The disease hasn't fully bloomed yet, so that slight outlier, that weird heart rate, that slight confusion might be the only clue that a massive infection is brewing.
So we've done serious, probable DIMES and outliers. Now we hit T timeout.
The final safety check. Before you admit or discharge, you take a distinct pause. It can be 30 seconds. It's metacognition. It's thinking about your thinking.
But practically speaking, in a loud ER, what are you actually asking yourself?
You're auditing your own brain. You ask, did I anchor on the first thing the triage nurse wrote down? That's diagnostic momentum. Did I stop looking because I found one thing wrong, like a UTI, and maybe missed the heart attack happening at the same time? That's search satisficing.
And there's an emotional check too, isn't there?
Yes. Affective bias is real. You ask yourself, am I hungry, angry, late, or tired? If a patient is rude to you, or if they're drunk and difficult, your brain wants to discharge them. It wants them gone.
It shrinks your empathy and your cognitive bandwidth.
It absolutely does. Acknowledging that, just saying to yourself, I am frustrated with this patient, allows you to reset and say, okay, I'm annoyed, but I still need to make sure they aren't dying.
This is so structured. It takes thinking clearly and turns it into a checklist.
Yeah.
But I have to play devil's advocate. We can tell doctors to think harder and use checklists, but if the system is broken, if they're seeing 4 patients an hour, is willpower enough?
No, absolutely not. And the report is very firm on this. You cannot cognitive force your way out of a broken system every single time. We need systemic safety nets.
Like what?
Things like the cone of silence.
Which sounds like a spy gadget.
I wish. Sadly, no. It's a designated physical zone where if a doctor is standing there, you do not interrupt them, period. They are doing high-stakes thinking. We need to respect that.
And what about when you send a patient home? The sources talk about E-triggers.
Right. Automated alerts. If a patient returns to the ED within 72 hours, the system should flag it immediately. That return visit is a high-risk moment. It often means the first diagnosis was wrong. It forces a rethink.
I want to touch on one last practical strategy. Sometimes, despite all this, you just don't know. You've run the test and you don't have a diagnosis.
And that is okay. Uncertainty is part of the job. You don't always need a name for the disease to treat the patient safely, but there is a specific way to handle it. It's called safety netting, or the not yet diagnosed strategy.
How do you communicate that without sounding like you don't know what you're doing?
You're honest, but you're specific. You say, look, we haven't found the specific name for what you have yet, but using our checklist, we have effectively ruled out the life-threatening stuff. You refer back to the S in SPOT. You tell them it's not your heart, it's not a clot, it's not a serious infection.
And then you give them the outliers to watch for.
Yes. You don't just say, come back if you feel worse. That's useless. You say, if you get a fever over 101, or if the pain moves to the right lower belly, or if you start vomiting, come back immediately. You deputize the patient to watch for the disease revealing itself.
Okay, so let's recap this whole journey. We started with the sheer danger of the ED environment and that vulnerability of System 1 thinking.
Right, that desire to just rely on intuition. We countered that by building a rigorous problem representation, forcing ourselves to translate back pain into vascular syndrome.
Then we ran the SPOTDX checklist. S for serious, rule out the killers. P for probable, run the dime sieve to catch the mimics. O for outliers, what doesn't fit. And T for timeout, check your bias.
So what here is really about metacognitive vigilance. It's not just about knowing medicine, it's about knowing how your own mind processes medicine.
The sources leave us with a final, really provocative thought. They talk about moving from safety 1 to safety 2.
This is a great shift to end on. Safety 1 is studying errors, what went wrong. We do morbidity and mortality conferences to autopsy our mistakes, and that's valuable.
Right.
But safety 2 is studying what goes right.
Because most of the time, 95% of the time, doctors do get it right, despite all the chaos.
Exactly. So the challenge to you, listening, is this. Next time you make a tricky diagnosis or you catch a subtle clue that saves a patient, don't just pat yourself on the back. Stop and ask yourself, what went right in my thinking process just now?
Did I reframe the problem? Did I notice an outlier that everyone else missed?
Yeah. Analyze your wins with the same rigor you analyze your losses. That is how you build true cognitive resilience.
Thank you so much for walking us through this. It's a fascinating look at the engine under the hood of medical decision-making.
My pleasure. It was great.
And to you, listening, thanks for joining us on this deep dive. Stay curious, stay sharp, and we'll catch you next time.